Hello, everyone. Welcome to the second episode of the ImagiQ Webinar Series. My name is Steve Beck. I'm the principal investigator of the ImagiQ project and a faculty member at the University of Iowa. It is my greatest pleasure to introduce today's speaker, Dr. Jayashree Kalpathy-Cramer. Dr. Kalpathy-Cramer is an associate professor of radiology at the Massachusetts General Hospital and Harvard Medical School. She co-directs the Quantitative Traditional Imaging in Medicine Laboratory, or QTIM laboratory, and the Center for Machine Learning at the Athinola A. Martino Center for Biomedical Imaging. She's also a scientific director at the MGH and BWH Center for Clinical Data Science. Dr. Kalpathy-Cramer works at the intersection of machine learning and healthcare with a focus on medical imaging. Her research areas include machine learning, informatics, image analysis, and statistical methods. In addition to developing novel machine learning algorithms, her lab is also actively engaged in the applications of these clinical problems in radiology, oncology, and ophthalmology. Today, she will give us a talk about some real-world challenges of AI in medicine, including the issues of brittleness and bias of AI models and explainable machine learning. So please join me in welcoming Dr. Kalpathy-Cramer.
Thank you so much for the introduction and the opportunity to speak here today. As mentioned, I'll be talking about some of the challenges that we have faced in the real-world applications of AI. A lot of this has come from our experience in trying to do this in both ophthalmology, oncology, and many different domains. But the examples here are broadly from the medical imaging space. Here are my disclosures. As everyone I'm sure is well aware, there's a lot of hope and hype about what AI and some of these methods can do in the healthcare arena. You really cannot get away from reading about that in the news as well as in the technical media. So there's a lot of scope for these methods, especially in areas of medicine that medical imaging has a key role, and areas such as oncology, ophthalmology, and radiology are areas that we work on. And the advantage with a lot of the work we can do here is that many methods developed in the computer vision community can be broadly applicable here. So for instance, a lot of the ImageNet pre-trained networks, for instance, you see them applied very often in radiology, for instance. So a lot of the techniques developed in more common computer science, computer vision area are making their way into medicine. Ophthalmology is an area where we saw some of the early work, applications of deep learning. That was one of the first large-scale publications in the use of diabetic retinopathy. We've been doing a lot of work in area of ophthalmology called retinopathy of prematurity, and I'll talk about that in a minute. But one reason why we saw a lot of the early work in this area is that many of these images are fundus photographs, and so they look a lot like sort of real-world images. They're color images, they're 2D. So it's fairly straightforward to sort of extrapolate some of the methods developed for cats and dog classification and apply them to fundus photography. In fact, one thing I'd like to point is one of the first AI algorithms approved by the FDA for purely sort of autonomous type AI came in this area and came out of your institution. So other areas where we see a lot of work is in radiation oncology, pathology. Again, many of these areas have a lot of images, and for things like segmentation or classification, many common networks can be used fairly straightforwardly. I'll spend a little time talking about retinopathy of prematurity. It's a disease affecting low birth weight babies, specifically babies that are below 1,250 grams or less than 31 weeks of gestation are screened for ROP. It is a leading cause of preventable blindness worldwide. It has a huge economic impact both in the US and even more so in low and middle income countries. And this, fortunately, there's a wide range of treatment options available if diagnosed early. However, the sort of biology underlying this disease is that it's the oxygen delivery in the context of ROP is that it's when babies are born prematurely, they are often given a lot of oxygen that helps them obviously survive. but that extra oxygen, the hypoxia, causes changes in the vasculature of the developing eye, and this can lead to a retinopathy. And the way the disease manifests itself is, if you look at the fundus of the eye, especially of these premature babies, you look at the sort of the vessels of the vessels, and you'll see that in the normal case, you should see pretty straight vessels that are not too dilated. But as the disease progresses, you start to see more and more of these tortuous and dilated vessels. And this is, essentially, the vessels look more and more squiggly. So the goal of a lot of the diagnostic process is to try to sort of categorize and diagnose these vessels, the eyes, in these different class categories. Once the eyes have plus disease, those babies are at high risk for developing treatment-requiring disease, and so they need to be monitored more carefully. So using fairly standard techniques, we developed a classification system for this ROP, especially for this plus disease, which is the hallmark of severe disease, and essentially you're looking at the vascular architecture. What we'll notice here is when we compared our algorithm to that of performance of clinicians, we see it, ROP, as you see very often, an ROC that you see typically published in the literature for these sort of classification networks. But interestingly, what you see is that the clinicians lie primarily on the ROC curve, but on different parts of the ROC curve. So our clinicians can be more sensitive or more specific. And this is something to keep in mind as we are developing and applying these algorithms in the real world. For instance, if you're creating an algorithm using data that is annotated by this clinician and then applying it to one annotated here, who lies this part of the spectrum, you'll see that there can be quite a bit of difference between how the algorithm performs in these two different settings. And so once we got an algorithm, we were very happy with it. We got FDA sort of breakthrough status from the FDA, and then we started thinking about applying it in the real world. Once we start doing that, we see a whole host of challenges when we come to real world deployment. So the first thing is that the eyes and the back of the eyes look quite different for different populations. And you can see that in the top left. So you can see sort of the pigmentation can be quite different. So if you develop an algorithm for one population and try to apply it elsewhere, then I think you can see that might pose some challenges. So a question was asked about the ratio between plus and non-plus, and that's a really good question, because something I forgot to mention is that the plus is very small in terms of fractions, so the relative prevalence is somewhere between 3 and 10% in terms of the prevalence. And so as you're developing your methods, that's something else you need to keep into account is, how do you train your network? Do you have balanced data? Do you have a more representative representation during your training process? Or potentially when you're training, you may sample more equally, but for testing, you need to make sure it works in the real world. So it's a good question, and something that is very hard about a lot of different aspects of medicine is that the prevalence tends to be low for many of these diseases. Going back to the challenges of real world deployment, we see that different camera systems can look quite different, both in terms of illumination and in terms of field of view. And again, if you've trained an algorithm for one camera system and try to apply it elsewhere, it may not work So as you're designing your applications and your networks, one thing to keep in mind is, how do you normalize for all of these things ahead of time so that the image going into the network looks similar, no matter if it's from different populations, different ethnicities, different camera systems. Another surprise we had was when we went to deploy our system in a hospital, or to look at data from a hospital in India, we suddenly came across these images that were actually sort of zoomed out views of the eye. And they, in some ways, they actually look to the network. They didn't look that dissimilar from the fundus photographs, but obviously they are completely different. And we really shouldn't be using these images into the network. So thinking about out of distribution differences and making sure that the images that are being fed into the network are sufficiently similar to the ones that they were trained on is important as we start to think about the deployment. A fairly common issue is the image quality. And again, this can be true whether you're talking about MRI or CT or pathology images or fundus photographs. If the images are of insufficient quality, it can be very hard for the network and for humans to actually make any diagnosis based on them. So thinking about how to deal with that is also important. And the disease itself can be different in different populations. Because of the biology of the disease and the interaction between the oxygenation and so on, what we find is in places that have potentially insufficient quality in place for how to deliver oxygen, we might see heavier babies with more severe disease. This is not something that one might see in the US population, but as we think about applying these more globally, we notice that the disease itself might be different, or even the screening criteria might be different. So thinking about how to make your algorithms more generalizable throughout is important. Going back to the quality issue, as you can see, the leftmost image has very poor quality. You can barely see the vessels. The right images have much better quality. The one in between is somewhat in between. And so one of the things that we had to do is actually create a first step of a quality detection or grading algorithm. This is again important, no matter what disease or other thing that you're thinking about, especially as you go to apply it in the real world, where the images may not be necessarily taken by a clinician, they may be taken by technologists, they may not be sort of immediate feedback about the quality. Going back a bit to the ROC curve issue, as mentioned, we can see that different people lie on different parts of the curve. And this is very, very common. If you look at pretty much any publication where they've had multiple raters, you'll see the same sort of phenomenon. People are very different in how they sort of treat diseases. And this is especially true for diseases that lie on a spectrum. So there's a lot of diagnostic variability. And as we think about training our algorithms using data that come from clinicians as ground truth, either prospectively acquired and graded or retrospectively acquired from the radiology report or ophthalmology report, we see that there's a lot of scope for variability. Real world is a continuous spectrum. Here is data again from ophthalmology. We took the same set of images and asked essentially 8 of the world's experts on the disease to grade them in this sort of 3-class category. And what you see right away is that the relative prevalence of each of these classes varies substantially among the experts. In the top row, this expert has a few reds and a lot of greens, but in the bottom row, this expert has a lot more reds relative to the green. And that's, if you sort of zoom in on the more severe part of the disease, you'll really see the sort of triangular shape to this graph, indicating that the cut point between, say, mild and moderate or moderate and severe can vary quite substantially. And again, that's reflected on where they lie on the ROC curve. Interestingly, what we found is if you ask people which is more severe, so is this given a pair of images, is this more severe or less severe? Even an engineer like me can look at it and say, this is much, much more severe. On the other hand, when you're starting to get images that are more close together, you'll see that it's maybe harder to make that decision. But once you have these sort of pairwise comparisons, and you can use sort of learning to rank type methods, you can get a nice ordered list of disease severity. And there we get much, much more consistent behavior. So as you're thinking about sort of training your networks and thinking about what is the best ground truth to use, for diseases that lie on a spectrum, we have found this approach of thinking about it as creating a quantitative scale, whether it's using a regression network or using pairwise comparisons, that potentially allows you to get a lot more agreement between the clinicians relative to making these sort of arbitrary cut points between disease severity scales. And I mean, we can sort of see that in our ability, the comparison rankings are much more consistent among raters than the classification rankings. So based on that, we chose to create severity scales, and we've done this for many different diseases. And that allows you to do a variety of different things. You can see, for instance, if the disease is getting better or worse within a patient. very often you see trends within a class. So even within plus or pre-plus, you might see that there's movement in terms of the disease, the eye progressing or responding. But because you've bent them into these 2 or 3 big classes, it's really hard to see that. So having a nice severity scale allows you to sort of look at things like who's getting better, who's getting worse. And so using a sort of Siamese network architecture, we found that we were able to create a nice continuous severity scale. And there you can use it to essentially say, okay, this baby's eye is not changing over time. This one, on the other hand, is getting much worse. And the ability to do sort of longitudinal change within a baby can go up when we do that. So based on that, we created again, a severity scale using a couple of different approaches, including Siamese networks, and showed that we can use it to monitor disease progression as well as disease response to therapy. Switching gears, radiology is where we've seen a lot of work as well in the use of these deep learning methods for a whole host of areas. Most of what we've seen, though, is in the right end of this graph, in that we see mostly in the diagnostic area. But we are starting to see a lot of applications in the earlier part of the space, so things like image reconstruction and so on. So thinking about how we might do similar things, we had COVID was obviously a big issue and continues to be a big issue for us. And so an area of interest was, can we grade, again, looking at the chest x-rays, can we come up with a nice severity scale rating? This might allow us to figure out who's going to get worse, who's decompensating, is this person improving, responding, and so on. So sort of this was a generalized need. There's really no, if you look at the radiology reports, there's nothing in them to say how sort of quantitatively say how severe the disease is. One radiologist mild might be another person's moderate. And so trying to create a nice standardized system is challenging. And so our goal was to try to do that using deep learning. And so we used ground truth created by radiologists in terms of this MRAL scale. Although we got a variety of clinicians to do that, the kappa between them was not very high. But if you look at sort of a consensus, we get pretty good results. So using that, we can train a network to, again, learn their severity. Just as in the ROP case, we find that people are more specific and sensitive, as you can see by this sort of the triangular nature here as well. And so we, similar network architecture, we are able to come up with a nice severity scale that allows us to then monitor and even do things like assessing who's at risk for intubation and so on. So based on our scale, we can see that if you have a pretty low scale, your risk of intubation is much, much lower compared to more severe disease. So it's becoming really easy to create AI algorithms today, as we see by the proliferation, both in the literature and everywhere else. One thing we are starting to see more of is sort of auto ML type approaches. So basically you take your annotations, you take your data, put it all into a funnel, and out pops a nice AI algorithm. And in fact, we're starting to see how that you can create abstracts. So in a not too distant future, we can see our AI algorithm going all the way from sort of raw data to the abstract. But it's really challenging to create these algorithms that are broad, general, generalizable, robust, unbiased, fair, self-aware, and tell you when they are not sure and maybe somebody else should take a look. So an example of the challenges is here. So this is from Dr. Dreyer. This is just a sort of landscape of radiology diagnostics. So we have so many different modalities, we have so many different anatomies and sort of findings. And if you think about the little grid here, what we often tend to do is be very, very narrow. So we might have a lung nodule, or we can have a knee ACL detector. But what we're actually filling out is this tiny space within this entire grid. So as we're thinking about the challenges of going from having one algorithm to having a whole suite of algorithms to having sort of head to toe covered, it continues to be very challenging. The other thing we've seen is that these models don't necessarily generalize well. So very few of these published studies have had external validation. One of the reasons that we see for that is data heterogeneity. So going back to the question, very often you'll see like either single test site or maybe cross-validation, but very, very rarely do you see external validation. Even fewer is sort of multi-site external validation, and obviously we'd eventually like to get to having randomized control trials as well. Some of the ways in which data heterogeneity can manifest is in the prevalence of the disease. So if you're looking at an inpatient setting versus an outpatient setting, or in a screening versus other settings in a place where there's a lot of the disease versus not, the prevalence can be quite different. The number of cases at multiple institutions can be different. The image acquisitions can be different. And all of this can lead to substantial degradation in the algorithm performance. So here, for instance, you're looking at the image acquisition. So we have different scanner types, and they all have different sort of histogram profiles. If you train an algorithm on scanner A and test it on scanner A, you see pretty good performance. But on the off-diagonal elements where you train on scanner A and test it on scanner C, you see that the performance has degraded substantially. On the other hand, if you have, and the interesting thing about it is if you look at the sort of the UMAPs of the network continues to retain information about the scanner throughout the network. So it knows exactly which data set came from which scanner throughout the network. What we had hoped was some of the normalization steps and things like that will sort of do some of the normalization for us, but we find out that it really doesn't. What it actually does is learns within each scanner distribution the gradation of disease severity, for instance. So something to sort of keep in mind is, look, these maps can be quite helpful in trying to look at distribution differences and actually trying to understand how the network is thinking about looking at the disease manifestations. So one solution for that is have a central database, and we see a lot of efforts nationally to do that. So it's great when these databases are put together with data from different sites. And if we do that, what we see is, as you see here, is that the algorithm now can learn to perform well for all sites. So if you're so fortunate as to have data from multiple sites, that's great. But the challenges, of course, are this is PHI data. There's a variety of reasons due to which institutions may not want or cannot share the data. So how do we then go about essentially learning from data from different institutions without having to share them or put them into a central repository? And that's where a lot of the work that we are doing with both Steve and Dr. Rubin is interesting, is that we are thinking of different ways of doing federated learning or collaborative learning approaches. So sort of the trivial way might be model ensembling, that you can train a model at each institution and then try to ensemble that and see how well that works. We found that it's not, even though ensembling often is very successful, in this particular case, we found it to not work as well. We can sort of do federated learning, and what we've been doing a lot is a cyclical weight transfer. It is another technical twist on how to do collaborative learning. And we've also been investigating things like split learning. In the federated averaging situation, which is probably what people are most familiar with, essentially you have a model at the central server, it goes down to each hospital, you train locally, you update the local weights, and this process sort of continues till you get convergence. We've done a real life implementation of this with a number of sites as part of a collaboration with NVIDIA and others. And we can show that even though the intensity distribution coming from the different scanners can look quite different, federated learning allows you to create a model that works pretty well for all sites. As mentioned in the cyclical weight transfer, we essentially sort of learn at each site and go sort of sequentially. And again, we show that this works quite well. Another thing I'd like to talk about is a question of bias. We've seen this everywhere, that there's AI is not just learning our biases, it's amplifying them. We see this in facial rec. We see this in the biases of healthcare risk algorithms. So all of these are really a concern. Some people might argue that it's just the data, but it's not just the data. There's many, many reasons why we are when we're training a model, we're sort of encoding what's already present in the data and trying to propagate that. And so but it's more than that. It's that there are some sort of structural reasons why biases can sort of creep into our algorithms. Different populations, different disease prevalences, as mentioned, different, if you're looking at different body profiles, again, the algorithms may work less or better or worse, different acquisitions. And so thinking about all of these questions as you're curating and training your data is important, but even more so when you try to do broad validation. So how do we do validation across institutions in a manner that's fair? How do you look at the fairness question? I'll come back to the question about federated learning in a minute, but I'm going to go on briefly to explainability and interpretability. So again, one reason why this is important is the notion of building trust. Many of these algorithms are black boxes, and the sense is that clinicians don't like black boxes. They would like the algorithm to tell them what's happening. As an aside, we found that clinicians are black boxes as well. They often just have this sort of gestalt as to why they say something about their decision-making process, and it's very hard to have them describe exactly what it is. We've done many of these studies where we sort of ask them to talk aloud and think aloud as they're making the decision-making process, and we find they are definitely black boxes as well. On the other hand, it is obviously desirable to have algorithms that are more explainable inherently. There's a lot of work that we've seen of late in these sort of post-hoc saliency map methods. GradCam is a very popular one, but there's many others. And here's a small list of them. And in fact, in the medical literature, you'll be very hard pressed to find a paper that does a classification network, for instance, that does not have a GradCams, whether it's radiology or ophthalmology and elsewhere. What you'll notice often, though, and as you can see this here, is often the areas highlighted have very little to do with the disease. They might pick up things like the marker. They might pick up sort of these shortcuts, as they are called, in the decision-making process. So when we're thinking about how to validate or think about these saliency maps, there's a number of different things to consider. Here is some interesting work that came out a couple of years ago at NeurIPS about the notion of sanity checks for saliency maps. Here's more recent work. This is in fact from this week, or maybe last week, that showed that they don't really do all that great a job. Here's some work that said they sort of select shortcuts of a signal, and here's some work that we at on medRxiv and arXiv on our proposal for how to think about these saliency maps. So in the original paper of sanity checks, what they did is they took these different methods and different saliency maps, and essentially, firstly, they noted that they look a lot like edge detectors. So they really are highlighting sort of the areas of most contrast potentially. And then they propose this approach where they start to, you take a trained network and in a cascading fashion, you randomize the weights. So essentially, you see what happens as you go from a fully trained network to a fully random network. And what you find is for some of the methods, you can randomize a lot of the network and still have the same sort of saliency map show up, which is obviously not desired. The other thing they did is they essentially took the true labels, but also trained a network with random labels, and again showed that the saliency maps seem to be unchanged, which is somewhat both surprising and alarming, and not exactly what we were hoping for, right? So the idea is that these saliency maps are explaining what the network is doing. But if you get the same saliency map, whether you have a trained network or a random network, then it's obviously not doing exactly what we are hoping it's doing. Another work that came out of this workshop, and this is a sort of ongoing workshop, is looking at these maps for, in this particular case, for cardiomegaly, which is essentially a heart condition. And what we often find is that the saliency maps highlight areas that are far away from that. And you don't have to be a clinician to know that this is not where your heart is. And so being somewhat skeptical of these is also potentially healthy. So some of a framework that we've come up with and that's been working for us is, are they good localizers? So for instance, if you have a data set where you have ground truth, either in the form of bounding boxes or segmentation, how often are the highlighted areas reflective of the true area of pathological concern? The other question is going back to the model randomization. And then there's a question of repeatability and reproducibility. If we are hoping that these saliency maps are reflecting underlying biology or pathology or something sort of fundamental about the disease, what we hope is that if you have two networks trained slightly, the same network, but trained with slightly different seeds, for instance, we hope that they come up with sort of similar looking maps. And very often, and we ideally would hope that even different networks come up with similar looking maps, but we find very, very often is they don't. So thinking about the question of saliency mapping and explainability, and especially in this area of medicine, one thing we might want to think about is how do we best sort of formulate the question. So if the question is, does this patient have pneumothorax or not? You could just say yes or no and train a classifier that way. And then use something like a post hoc method to try to say where it is using a heat map. And this is what we see very often. A different approach is maybe you have a detection network where you have a bounding box, and there you are sort of inherently much more explainable. And we found this to be a useful approach, especially in radiology. So for instance, if you have the task is to do a fracture detection, and if all of the output of the network just says here's a fracture or not, and the clinician is sort of scrolling up and down and trying to figure out where the fracture is, it might end up wasting a lot more of their time. So much better would be to either highlight the area of concern or something like that, because then they can either accept it or dismiss it right away without having to sort of go up and down trying to see, is there a fracture here, is there a fracture here, and then getting frustrated when they don't find that. Another approach is segmentation. So again, both of these on the right are a little more inherently explainable than a purely classification network. So highly encourage you, for those of us, especially on the technical side, to really work with the clinicians to try to understand what is the real question that they are trying to answer and train the network to satisfy that, as opposed to sort of thinking maybe a classification network will get you most of the way there. So sort of thinking about, are you solving the correct problem? Are you solving it correctly? How do we think about the sort of the final mile? Now that you have a network, how do you deploy it? Do you deploy it? What are the regulatory concerns as you're thinking about deployment? How do you evaluate the model brittleness? So you have a model and then you've trained it on your data, you run it locally. Now you give it to your colleagues for a research study, for instance, and it doesn't work. Now what? How do you think about that? Very often people use transfer learning, for instance, so they might essentially learn at one site and send the network over, and then with a small amount of fine-tuning, maybe it can perform quite well at the other site. But how do you, what are the best methods to do that? So again, working closely with our clinicians, we've found that that is really the key, is this really tight interactions between the clinical and the technical folk, and then having the infrastructure to do sort of large scale deployment and evaluation. So for instance, if you have a nice infrastructure that allows you to deploy the model, you can run it in shadow mode and see how well the model performs without necessarily providing that information to the clinician. You can compare the output of the model with the reports, for instance, all in shadow mode. And that'll allow you to get a pretty good understanding of how brittle the model is or not. The other thing you might want to think about is the sort of subset analysis to see if the algorithm works just as well for all populations. What we see very often is a single metric, like an ROC, AUROC, or sensitivity or specificity for the algorithm in the population. But what we don't really see is sort of the question about how well does it do in subpopulations? So if you have a minority class and the minority class is very rare, you may completely miss the fact that the model is like really horrible for that minority class because you're just reporting statistics for the entire population. So thinking about how to set this up and how to set it up in a way that you can monitor and continue to monitor, not just sort of broadly and see when the algorithm is not working anymore, but also for the subpopulations of interest. So some of the things we've learned along the way is that we need lots and lots of data, especially as we think about deep learning. We are starting to see these wonderful resources made public by RSNA and many other societies. And those, we really appreciate the generosity of both the institutions and the various people doing that, especially because very often they come with really highly annotated data. So for many of us on the methods side, that allows us to develop our methods on public data sets, which is really important when you think about the reproducibility of science. When we go to publish, very often we are required to sort of share our code, have it in a way that can be reproduced, and these public resources can be phenomenal for that. As mentioned, many of these models can be biased. We really need to sort of examine the data and the models carefully. They can be brittle. So thinking about how to facilitate external validation is important. Federated learning is really great, I think. I'm biased, but I think that's a really good approach. But there's also this notion of federated, not just training, but federated validation. So the American College of Radiology through AI Lab and many other efforts are being developed to allow for this. So the idea being that you don't, as a hospital trying to evaluate an algorithm, you don't necessarily want to share your data outside, but can you have an infrastructure that allows you to compare different algorithms? So an infrastructure, especially one where you can sort of pull data from your packs, you can annotate it yourself, and then see how well these external algorithms might work on your data. That allows you to sort of build trust in the algorithm and evaluate how well it works. The notion of annotations being noisy and biased is really important. And if you see many of the large publications, what they typically have is multiple annotators per case. So just so that you're not taking sort of a one person's view on the situation, but you're looking at consensus and so on. So the other thing as mentioned is that when you have diseases that lie on a spectrum, people tend to have very different cut points. So that the boundary between mild and moderate can be quite different for quite different people. And some of these sort of are institutionalized in the sense that many people at a single practice might do things very similarly, but somewhere else they may do it differently. And there are many good reasons for why that might happen, because potentially the ramifications of different outcomes are different in different populations. So people might be more concerned and might tend to overcall or undercall. So thinking of from a methods perspective, how to deal with that, I think is an interesting area of research. So sort of some final thoughts is that we see a lot of great potential, but we really are limited by the kind of data we tend to have access to. And more than anything else, collaboration is key. So with that, I'd like to thank a lot of the people in our lab that helped with a lot of this. I see a number of questions. I'm going to try to answer them in a second. So is federated learning better than approaches? That's a good question. I don't know that. I think what you'll see, as with everything else in the literature, is that every publication will say that their method is better than everybody else's. And so I think we need to do as a field, we need to do much more of a better job in terms of trying to compare these different methods. For our personal experience, we found that some of the methods we have, like the cyclical weight transfer, outperformed the standard federated learning, but it also you have to think a lot about how a variety of things in terms of network architecture, things like batch norm can be very important in terms of how you set it up. And so, I would say the question as to what is the best way of doing federated learning is still an open question from our experience. And I would love to collaborate with people, and that's why we're excited about this collaboration with Steve, but in anybody else who's interested, I think it's a great opportunity as a field to sort of address that question. The next question was federated learning versus transfer learning, and it's sort of going back to the previous question about personalized federated learning. So I think it's a good question as well. What some people have reported is that the best central model may not be the best local model. And so, for instance, what people might do is do this federated learning till it converges, but then do a small amount of fine-tuning using transfer learning at the very end. And that seems to work in some situations. And an analogy that people have mentioned is like your phone and voice recognition, right? So there's, I mean, as all of these voice recognition techniques are getting better and more, getting access to more and more data, they get more and more robust, but your phone sort of learns to recognize you. So your final model has sort of been fine-tuned for you. So some people argue that what we really need is almost an overfit model, meaning it's for each institution, we have a model that's highly specific to that institution. But again, an open area of research, and we don't, the regulatory implications of that are pretty daunting. So how do we think about having sort of personalized models for each institution? How does the FDA regulate that? So really good question. I don't know that I have the answer, and I don't know that the FDA has an answer quite yet, but I think we'll continue to hear more about that. So the next question was the proxies. I think that's a huge issue. I don't know that I have a good answer again about how to stop it preventing these systems from learning proxies, other than our approach has been to try to sort of steer people towards building models that are inherently more interpretable. But the shortcut issue is still there. So I would say it's a continued area of research. Yeah. And again, if you have suggestions, I would love to hear them. The interpretability question, I think many people are working on it, many answers, but one possible approach is to think about models that are inherently more interpretable, such as sort of having the task come up with localizations spatially. So if you think about other approaches where deep learning might be used when you're combining data from multiple sources and you have a whole host of features, it can be very hard to figure out exactly what the feature is. So what we found to be potentially an interesting approach to consider is that use deep learning for doing things like quantifying the severity of a disease on an X-ray, where it's a clinician can look at it and say yes or no and sort of agree with it, but then combine that numbers with the other parameters using more sort of even something like logistic regression. So when you're building a risk model, for instance, that it's trying to incorporate both the images and the clinical parameters, as opposed to putting everything into a black box, and which we've done and works really well. But there it's very hard to sort of disentangle what is causing the network to make that decision. We found it potentially more interpretable when we can say, okay, based on the image, the risk score is this much, but then we can combine it with other clinical parameters in a more, something like logistic regression, where we know right away what the weights of the different things are. So. Any other questions?
All right, if there's any further question, I think this concludes today's webinar session of Dr. Kalpathy-Cramer. I would like to thank all of the audience today for their participation, as well as our speaker for the very interesting talk. Thank you again, and have a great rest of your day.